Thank you very much, Dr. Sheetal, for that kind introduction. And it's a wonderful course that you've been conducting. I have unfortunately a series of several such cases which I wish I never had. But unfortunately, many of us will be facing it from time to time. That irrespective of just because it's a toric IOL plant doesn't mean you cannot have an intraoperative complication. So this is a second eye of a 53-year-old male. Absolutely nothing in it. The Lensex with toric IOL was being planned, grade 2 cataract, and there's nothing in the eye or in the planning that would have made us think otherwise. The placement axis was also along the lines of the incision. The femtosecond had done a good job, done a nice capsular axis. Lens division was also assisted by the femtosecond, and we are going ahead smoothly with lens division using moderate parameters. So things are happening quite slowly because of these lower parameters, but they usually tend to happen under our control. So we find it quite safe to work with these lower parameters of around 20 cc flow rate and bottle height ranging from 30 to 50 depending on the eye or the compliance of the globe. So everything has gone off well, nice centered capsular axis, and now time for IOL implantation. It was a T3 IOL 20 diopter, and it's been injected in the normal way. But notice just one thing here. The plunger is actually overriding on the IOL. So generally you would want the plunger to be at the optic haptic junction, but it's overriding the IOL. And therefore this we are facing a little bit of resistance in trying to inject it, and there it came out with a jerk. So let's review that again. The IOL is being nicely pushed, the plunger is on top, and therefore that jerk. Generally nothing happens and everything goes, and that's what we felt, that nothing would have happened. But to our horror, we have injected a toric IOL in the bag, and we have created this nice up to the equator posterior capsule blend. Now this is a tricky situation because not only is this a single piece IOL in the bag, it is also a toric IOL. So whatever we do with it, if we have to leave it in the bag, it has to be stable. You can't leave it just like that. The safest would be to explant it and put a three-piece IOL in the sulcus. But having had a few such cases in the past, we decided to use the option of reverse capturing it, which means you let the haptics remain in the bag, but you pop out the optic in front of the anterior capsule. It is quite time consuming because by the time you pop out one, the other can tilt because there's a lot of cohesive viscoelastic inside the eye at this point of time. But finally, we are managing to make sure that the optic comes up, and this is how the capture would generally look. You will have a very broad. So this indicates the optic is in front, but you will have a very broad base at the optic haptic junction, unlike a three-piece capture or a conventional capture where the optic is pushed down. So we could manage to reverse capture. And of course, you have to make sure that during all of these maneuvers, no vitreous has prolapsed through the area of the posterior capsule rupture. Fortunately, it wasn't. The IOL was placed on its axis like we had shown previously at 168 degrees. The Varian overlay is not shown in the recording here. And make sure that you don't withdraw your irrigation before hydrating all the wounds. This is the patient at the end of surgery, nice reverse optic captured IOL, toric in its place. And fortunately, if the capture has occurred well, it will remain like this. So this is the patient 3 months, no problems at all. And this is the patient stable, the reverse capture very stable. Of course, this patient is likely to have more inflammation post-op, more chances of IOP post-op. So typically we would give mannitol post-operatively immediately once the patient goes in the room, and probably topical IOP lowering medications with maybe an increased frequency of topical steroids for a few days. Now coming from the anterior to the from the posterior to the anterior part. So again, another innocuous looking cataract. You can notice here the surgeon is focused more on the posterior capsule. So the focusing is not correct. You should be focused. You should be able to see the anterior capsule margin correctly, but everything has gone off well so far. A soft cataract, so 4 quadrants were done, but you can see that most of it is almost in a single piece. So the actual 4 divisions weren't completely done. But in soft cataracts, you can get away with this because the material is not very dense. So even if it's a large fragment, it generally doesn't cause any damage to the posterior capsule. If this was a very hard luminescent cataract, we would caution not only for damage to the endothelium, but tumbling of these fragments can cause PCR as well. But having removed most of the fragments, I've started to see something behind these fragments. So notice here that the anterior capsule has given way, and this probably would have occurred during this large fragment removal with the probe going somewhere there. And with the osil or with the sideways cutting tips, it's very easy to catch the capsule and cut away. So the first thing that you want to do is, once again, make sure that the chamber doesn't collapse. And here you need dispersive viscoelastic, not cohesive, because cohesive will easily come out. So dispersive viscoelastic to form the chamber, and then bring out the phaco probe. Use low parameters in this situation. So I've reduced my flow rate to 16 cc from 20 cc so that I don't inadvertently catch anything in the fornix except for the cortical material. And we could remove the cortex safely without making sure that this capsular tear doesn't extend to the equator. Now the tricky situation is you have a half open anterior capsule. If it was a non-toric, the decision is not very difficult because you go ahead and place a single piece in the bag. If you have 3/4 of the cover, it should be okay. But being a toric, you want to make sure that this doesn't rotate post-operatively. And of course, when things go wrong, they always go wrong. So this patient, the placement axis was exactly in the area of the anterior capsule split. Here, I would definitely suggest injecting under viscoelastic because it will allow you a lot of time to manipulate the IOL and it will open very slowly. So we make sure that slowly we nudge the IOL into the capsular bag without causing too much of turbulence or disturbance. And then we rotate the IOL in its desired placement axis before removing the viscoelastic. Here, you don't necessarily need to go behind the IOL because there's already an open area. So the viscoelastic will pop out from there. And this is the patient at the end of surgery. We thought the IOL is stable, and it's the best would be to check post-operatively. And this is the patient at 2 months. Some amount of fibrosis has occurred, but the IOL is very stable. So our experience has been that even in these anterior capsule splits, if the rest of the things are managed well, you can definitely consider toric IOL in the bag in such situations. This is a posterior polar young patient, not experienced press myopia. So we had explained to him that we might consider a multifocal toric if we are able to preserve the support. And we prefer femtodelineation in such situations where no hydrodelineation needs to be performed. And the lens is divided into 3 cylindrical ring zones. So we are removing each zone from the support or the cushion of the other. So until the last point, the posterior polar part remains protected. And after the central nucleus is removed, while removing the epinucleus, you don't completely remove it. So you just detach it. So now it creates a communication between the anterior and the posterior segment. So some amount of fluid will trickle back. And therefore, now even if you do a hydrodissection, this capsule will not rupture. And fortunately, following all of these principles, we were able to preserve the posterior capsule until the end. And case seems to be tackled for now, and we are now started scrubbing and preparing for the next case. But sometimes you get over and above yourself, and this was one such case where overconfidence took over, and I thought, let me just polish this plaque since I'm doing a multifocal toric. But as they say, never touch the posterior capsule of a posterior polar. And from what was an uneventful surgery, it's now converted into an eventful procedure. So now you have this nice oval tear where everything had gone off perfectly. Now is the time not to panic. Once again, do not withdraw your instruments. And having a past experience of pediatric cataract surgery, I think one thing we have found useful is that if you can convert a posterior capsular tear into a posterior capsular rexis and give it strong margins, you can still consider in the bag IOL implantation. So that is what I'm slowly but surely trying to do. And you need to make sure that you convert it from both sides. So one, I've done it, I'm almost completing it from this side, but that's not enough. We need to convert it from the other side as well. So you go ahead and convert it from the other side so that both sides, the margin becomes rounded and it's not a sharp pointed margin, because Whenever it's not converted into a strong margin, there are very high chances that the moment you inject IOL, it can split and rupture further. So since we have a strong anterior and posterior capsular excess margin, we went ahead with our plan of in the bag multifocal toric IOL in this patient. Once again, stability was not something that we were overtly concerned about. Make sure in the end that there is no vitreous disturbance by injecting alone. And this is the patient at the end of surgery, and this is the patient 3 months post-operatively with a very stable multifocal toric IOL. So I think I have one or two more cases, but I think we can stop here for discussion.